Welcome everybody, bienvenue tout le monde. Je suis Marion Dove, I'm Marion Dove, I'm chair of the Department of Family Medicine at McGill, and I am delighted to welcome all of you here in person et tout le monde qui est avec nous en Zoom, bienvenue. I would like to start with a land acknowledgement. So McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. So you are at the webinar and seminar entitled Death of a Platitude, the Limits of Foundational Concepts in Primary Care. And we are delighted to have two stellar speakers who zoomed in today from outer space to talk to us. They are inspiring, like asteroids. So Danielle Martin is the chair of the Department of Family and Community Medicine and a professor in the Institute for Health Policy Management and Evaluation at the School of Public Policy and Governance at the University of Toronto. She's a clinician and teacher at Women's College Hospital, where she has served as executive vice president, lead medical executive, and the medical lead of the hospital's pandemic response, as well as co-founding the Institute for Health System Solutions and Virtual Care. She was named Canada's 8th most powerful doctor by the Medical Post. I don't know, that must be a mistake, because I would say first, but anyway, 8th. They had some slip-ups with their numbers by the Medical Post in September 2015, and she's a regular contributor in the media. And on top of that, she's former president of Canadian Doctors for Medicare and a total inspiration to me. And you know, every now and then she gets invited to give a talk, and I'm like, how come they invited the chair of U of T and not the chair of McGill? And I'm like, oh, because she's Danielle Martin. She's like really impressive. And she is joined today by Pierre-Gerlier Forest, who is the CEO of the Institut national de santé publique du Québec. He has been a professor at several Canadian and American universities, including Université Laval, Université de Montréal, and the Johns Hopkins Bloomberg School of Public Health. He is a professor of public health at the University of Calgary, and until 2021, he's held the James S. and Barbara Chair in Research, a Palmer in Public Policy at the same university. Excuse me, I got my timing off on that. He has an excellent knowledge of federal and provincial public health. He has advised governments, health organizations, and research institutions in Canada, the United States, and Europe. So I want to thank you both for being here today, and I would love to turn the floor over to you.
Thank you so much, Marion.
Danielle, can I add just one thing?
Please.
I told many people already, but I'm very happy to be here today. I was there when this outpost was created back in the 1980s. And I was one of the architects of this thing. So I'm very proud to see it has survived. And okay, you moved down the hill, but that's okay. It's I like the building, but the atmosphere is the same.
Merci. Well, thank you to McGill University, to the Department of Family Medicine, Marion, and thank you, Kim, and to the School of Global and Population Health, and all of our colleagues for inviting us today. And for giving us the opportunity to get the band back together again, because PG and I have worked together over many years and really enjoy what we're about to do, which is hot debate and challenging assumptions. And so in keeping with that, we would like to request that this conversation be a Chatham House Rules conversation, that people not use social media with attribution in this discussion, so that we can really have a free flow of ideas, and particularly for my colleague who's a public servant, so that he can speak his mind and we can all speak our minds and debate with one another in the spirit of good academics. What the best of universities have to offer is to challenge our assumptions. So we were challenged today to talk a little bit about health human resources and primary care, as is in keeping with this seminar series. And of course, that led us to some of the most foundational work about primary care. Why should we care about primary care? What's the big deal with primary care anyway? Why are we so obsessed with talking about it in health systems? And of course, the orthodoxy on primary care comes down effectively to the evidence in these three dimensions. The first is that health systems that are founded on a strong foundation of primary healthcare produce better health outcomes. The second is that those outcomes are more equitable. And the third is that they do so at lower cost than systems that are not founded in strong primary care. And of course, we know this to be true. There's a mountain of evidence domestically, internationally, over decades and decades all over the world to that effect. And so what's the problem then? Why is it so hard to move? You know, as we slam our fist on the table and say, well, the evidence says it is thus, then why is it so difficult to move health systems? And one of the things that we want to interrogate today is why that might be. Because this is the reality that we find ourselves today. Work led by my colleague, Dr. Tara Kieran at the University of Toronto, and an extraordinary national group of collaborators in which they have gone out and spoken to residents of Canada using surveys, using deliberative democracy, community informed methods of bringing people together and having conversations. And what they are finding is that we are not delivering on this promise of better outcomes and better equity and lower costs. And indeed, that 22% of people, of adults in this country today are reporting that they do not have effectively access to primary care. They don't have a family physician or a nurse practitioner or a team that they see as their home. And of course, unfortunately, here in Quebec is one of the worst provinces for those reporting rates. And we all can talk a little bit today about why that might be. And so what we discussed, PG and I, was then, you know, what are the,
In the end, we are the two Fridas.
We are the two Fridas.
That.
And we have a good cop, bad cop shtick that we have practiced and honed over many years of working together. And so we thought we would share with you some of the conversation that we have with each other, in which I say things like relationship-based primary care is the foundation of health systems, and actually, maybe you were right. Relationships, these are the true sacred founding concepts of primary care. Relationships, who cares about them anyway? Are they really worth waiting for? Data, does it matter so much actually? And are we focusing our conversations about data in the right places? And integration, is it an obsession with vertical integration that is slowing down our progress in the places that really matter? And so what we want to do today is not to disrespect these foundational concepts, of course, to a point. We believe in them, of course, and we understand and believe in the evidence, but we do want to push ourselves to ask, when does our tight grasp of these concepts serve us, and when actually might it slow us down, and how might we think about them differently? And so here we are, the two Fridas, myself and PG, transfusing each other with good ideas and hot debate. And I will hand it to you, PG.
Which one is you?
Oh, you know, we're going to take a vote at the end, actually. We're going to take a vote at the end and you can decide. Okay,
so before, you know, when we started talking about this presentation a few months ago, just at that moment, there has been about, I don't know, 3 or 4 new op-eds in the national press about, you know, we need a primary care system in this country, and blah, blah, blah. And I was very irritated because I have read this piece for 30 years and I'm tired of that. Nothing is moving. You know, I don't know if those of you remember the late Health Council, but you know, one of the things that irritated me the most at the time is that on their website, they had a vignette about the Sault Ste. Marie Community Clinic. And they say, you know, at some point, they might have discovered that it didn't work just showing people this and hoping it would replicate. It never did. So maybe there was something wrong in the first place. Maybe there was the condition for replication were not there, even in this very model that they were still talking about and talking. And so I started to tell Danielle what we should do is go to some of those foundational concepts, that are repeated like platitudes in every op-ed that is written about primary care, and start questioning them and say, is that true? Or where is the part of truth in those platitudes? And the relationship is the first where we start talking about. Back in my times at Hopkins, I was there during the years of the implementation of the ACA, Accountable Care Act. And one of the things the ACA did, and did pretty well, is that it gave access to healthcare to a part of the population that was not covered by Medicaid, but was too poor in the back to do other things than go to the ED when it was very, very, very important. So suddenly people were able to seek care. And this market was cornered immediately by big pharmacy chains and by Target and the Walmarts of the world. And I found this was a very interesting experiment because people vote with their feet in that case. They immediately adopt the model. And we start talking to these people because why it was cheap? The quality was very high. Because if you're a Target, you cannot risk to be sued for malpractice. So what you're doing is that you make sure that you're following every single piece of evidence that is available when you provide the care. And we had people telling us, yeah, this is basically a, upscale walk-in. They say, yeah, it's true, but I get the care I was never able to exceed. And the other thing is, I said, yeah, but the relationship, all this about the need to build relationship. See, I could take care of the cuddling myself at home. I know if I could access care at a reasonable cost, I will take care of it. And there's truth behind that. It's not only the pun. The truth is that the social links, the social community, the social white, middle-class, male, well-educated. I'm very happy I have an equal relationship with my physician. I'm very happy I could have conversation with him, who is also male, blah, 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 about not only my health situation, but jazz and what is going on in town and so on. Very good, I had the relationship. But maybe it's not necessary. Maybe it shouldn't be subsidized. And I see the same in Alberta when I do those, radio show where people are calling and say, well, what they like in this health system. And Dr. Ford, could you explain? Yeah, outside of Quebec, I'm a doctor too. So they could explain what people are thinking, etc. And there are people, oh, I so like the system here. The doctor will spontaneously call me to tell me, he's like a friend. They don't realize it was subsidized friendship. And so I said, well, do really we need that in the system? I'm not sure.
Yeah, so I mean, of course, every fiber of my being bucks against this notion that the relationship is unnecessary. But I think the other way to ask the question is, so I agree with you, we don't need the subsidized cuddling. But so where do we know that the relationship actually contributes to the effectiveness of the intervention, which is care? And I would say that is when we start talking about management of chronic disease. And so insofar as people perceive that their need is an episodic need, perhaps it is irrelevant. But once we start talking about the ongoing management of chronic illness, or people, whether it's mental illness, whether it's diabetes, whether it's cancer, et cetera, then I think, then we're into a zone actually where, and maybe if we substitute the word longitudinality for the word relationship, it's easier to swallow because it feels less like cuddling and more like an intervention, then the longitudinality begins to matter. And so the question is, and I think it's an open question, do we trust ourselves and each other as grown-ups to determine when we need which of those things? Or do we, or is there a behavioral economics aspect to this, which is to say, you might think you only need the episodic thing, but you don't know that tomorrow is the day that you're going to start to need the longitudinal thing. And if we haven't set that up for you, then you're going to be in trouble. And so our best bet is to set it up for each other. So we're going to open it to the group now and ask.
Can I just, one point? The only point is, can't we train also the primary care or docs and nurses so that they could actually appreciate that need and not do that as a recipe, saying, I absolutely need to spend 45 minutes with my client because I need to build a relationship. This is BS, maybe not for every client at every moment, and have them trained to look at the social links between this patient and its community, its care community, the people, the family, and so on. This should be part of the training to be able to appreciate and not apply the relationship thing as, just like a union request. We need the time for building relationship. Ridiculous.
Please.
So I had a clinic this morning, I just ran over. And first of all, no one spends 45 minutes with a patient anymore. It just doesn't exist anymore. So I think that's a little bit pie in the sky. We would love to be able to do that. I think another example from this morning is I have a patient I've known for about 20 years. I followed the whole family through, their daughter's death from a, neurodegenerative disease. I know their environment. I know other families who have come to me, and she says to me, well, their friend who I happen to follow as well, she's consuming a lot more drugs now. And I said, what's so interesting, if I didn't have a relationship with you and I didn't know the context that you and my other patients live in, I wouldn't even be able to get this information. So I think there is a value to longitudinal community-based care that only comes with having a relationship over time. And it doesn't mean it has to be heavily subsidized, right? Because it means that you have an opportunity to get to know people over time. So I think it has a value. Now, I think it's, the question is, how can you create that without overburdening the one person who you expect to have that relationship with, right? So I think that's one of our challenges. I also think another thing that becomes very important in terms of having a longitudinal relationship is shared decision-making. It's very hard to do shared decision-making with someone you don't have any relationship with. And I think that really drives the cost to our system significantly. I see it in the walk-in clinic, which is just 2 floors up, where I also, see patients who have no one or their physicians aren't available. And the amount of investigation and referrals that comes from that episodic type of care, I think is very large. And so I just want to throw that out, that I think there is value on the individual level and the community level to having some longitudinal relationships, and that there's also a value to the cost to the system when you have people who are invested in each other.
So these are great points, and I'll just remind everyone, because this is a human resources conversation. So the question, I think the challenge for us is, if we believe that there is a value to this relationship, and we've got 20% of the Canadian population that can't access it, and let's just agree that Marion and I cannot produce enough family doctors quickly enough to close that gap, then what are the alternatives? What is the minimum viable product? Is that what the tech people call it, for relationship?
Well, I guess I wasn't gonna go there, but you kind of like landed it, and I'm a sociologist. I'm not the family doctor, and so I'm gonna throw it out there that maybe it doesn't need to rest all on the shoulders of family doctors. Good, but beyond that, what I was gonna say is, I think we know, there's a lot of hand ringing in public health and health promotion that information is not enough to move behavior. So I feel that what has been evoked here is a question of trust and also a question of information sharing, which arises from trust building. And insofar as we are looking increasingly at more and more diverse populations, I think that is excruciatingly critical to make sure that in situations where there is a power imbalance between the clinician and the person receiving care, that there is something of a trust building, because otherwise, again, what's going to move behavior, the behavioral change is not going to occur just by sharing information. I think we need to kind of agree on that. And the example you gave was one of power, a power balance, essentially. So, it's a fruitful relationship, possibly notably
think those are great points, and I just, I would invite also our colleagues in the room who've had experience in the global context to maybe comment on this. How do we build relationships? How do we build them by proxy? How do we build trust in community when the physician is the resource in short supply? Yes, please.
The online people would like to have the mic.
All right. Hi, online people. I just want to, you just mentioned the global context, so I want to add that too, but I also want to say that, you know, relationships are important. I'm not debating that, but I think at this point, the challenge is at the systems level, like how do we change our system to reach these goals? So human resources is one challenge, but how are we going to manage the finances and then orient our systems to balance this, which I think is Canada is facing, America is facing. And on the other hand, in low and middle income countries, because high income countries need more family doctors, there's this brain drain where Nigerian physicians, other physicians are flocking to NHS or other countries. So they are struggling too. I'm from Sri Lanka. Sri Lankan health systems is struggling with the same problem right now. And so I was at a previous talk of the same series, and Costa Rica had come up with the telehealth system, which doesn't always work, but you know, you have to orient it, I think. So, you know, I am wondering, like, how do we, while recognizing the problem, how can we improve our systems to take this forward? So I would like to put that to the experts.
Yeah, and I'll maybe just say something, you know, something on that front, just with respect to the evidence around virtual care that colleagues I work with have been involved in looking at. You know, it seems that the virtual care experience in the pandemic, at least in our Canadian context, has been that where it is used between a clinician and a patient who have a relationship, it seems to lower emergency department use. And in fact, probably also those people who have a virtual visit with their own provider and then go to the emergency department are more likely to be admitted. In other words, it's probably a more appropriate use of the emergency department. They're going because they're in serious trouble and need to be admitted to hospital. But that virtual care, when decoupled from relationship, all of these, you know, the rise of the corporate virtual walk-in clinic seems to drive greater emergency department use. And so, you know, it's a great example of how a tool, when applied in the presence or absence of a relationship, talks about segmenting, you know, healthcare services. So you should have the solutions shop, or like a Mayo Clinic, where people go when they have a really complex. Oh, I'm sorry. The notion that you would have a place where people go when they have a complex thing that requires heavy diagnostic, and then you would have that would be segmented out from the episodic thing, which would also be segmented out. So you're really applying different levels of care and different models to different kinds of populations. And to me, the problem with that is, of course, people don't come segmented. They come with the need for all of these things over the course of a lifetime. And so it becomes incredibly bizarre then to say to them, well, when you have this kind of problem, you go here. When you have that kind of problem, you go there. Any final thoughts before we go to data?
Maybe 2 points. The first is, I can't remember its name now. It's stupid, but this sociologist at UQAM that has been working on vulnerable groups and their use of the health system, and has shown that relationships could be detrimental to patients from time to time when the physicians are keeping their patients. You know, for instance, will never refer them because why would they need it anyway? You know, sure. And so on and so forth. So thinking that relationships are always good, I think, is wrong, and it should be seen always from a critical perspective. The second point is that it depends, you know, personally, I think at this moment we have a problem, and most people feel that they have a problem with access and cost. And I'm not saying relationships are not important, but if we don't solve the access and cost issue, well, it becomes, you know, basically moot. You know, I have to relinquish my spot in this very place in 2006, so I know that access is a problem.
Okay,
There are a
so,
couple of comments in the chat.
yes, please.
Thank you. So there's a lot, and I'm not going to read them all because I think we probably should, as you say, go on to data, but there's an interesting comment from Anish saying, build trust with communities when you are part of the community. We often separate our job as clinicians, researchers, and our social context. In Toronto, we have the added context of working in one city and living over an hour and a half away. But if we really want to establish trust quickly and acknowledgement in our limited time and resources, we need to consider what it means for us to be part of the clinic.
Yeah, that's a great comment. And we've been, some of us hot on this public education thing around thinking about your primary care environment like your public school. So you move into the neighborhood, your kid can go to the public school. Nobody says, well, we're not taking children, or, you'll have to go on a wait list or whatever. You don't have to, ask your friend if they could ask the teacher if your teacher would take the child. They just automatically can go. But no one would also permit that public school should then have a classroom with 50 kids in it. So we resource the school to respond to the need that exists in the community. And I think those two things have to be said in the same breath, because otherwise the conversation about access and geography basically becomes a conversation of yelling louder at people that they need to take on more patients, and we run into
Can I just
trouble.
add to that? One of the
Please.
challenges we have is that because of the relationship with our patients, when they leave this neighborhood, then they continue to stay with us.
Yeah.
So the challenge is that we keep patients who actually are in different neighborhoods, and then we are not accessible to those in this neighborhood.
They stay in the same public
Yep.
school.
One of the
Yeah.
many
Same as
downsides,
school, yeah.
and that's a great example of relationship trumping reason. And so we have to think about when is that logical and when is it not. Okay. So just to say about on the Our Care survey, so those who follow the work of Rebecca Etz, one of the great primary care researchers, will know that she has this validated tool around the 11 elements of primary care relationship. And I'm blanking on the name of it right now, but anyway, someone in the chat will help me out. And when they surveyed Canadian residents, so not just citizens, but residents of Canada, about what do they think is the most important thing, they talk about these elements that I think many of us would associate with relationships. So the patients had ranked that being known as a person and considering all of the factors that affect their health is extreme. People in this country anyway are defining relationship. Okay, so now we want to talk a little bit about data. We've all written about data. We think it's really important, et cetera. But like, when is it really important? And when are we just wasting our time trying to build, temples to information that we don't actually access or use in any meaningful way? And how much of the energy that's being put into data infrastructure in the Canadian context today is energy that might be better used elsewhere, is where we want to push ourselves. So I'm going to hand it to Bad Cop here.
Yeah, I'm just back from a conference where I spent a day and a half with people that are mostly Americans, but they're thinking, and I tend to agree, is that only medical care and care represents basically only 5% of the needs of the people they serve, and therefore that the importance of data in that world is essential, because we need information about the 95 or the 90% that is left. Daniel and I, we work on this question of what to do with data, and it's clear that the holy grail at this moment, at least in America, is to find a way to connect what we know at population level with what we know at community level and what we know at clinical or individual level. Everybody is trying to find a way to connect those three levels. The thing though is that it's not clear that at individual level, knowing a lot about the individual determinants of a patient, I will call it him or her a patient for the sake of the conversation, is really helpful. Because in the end, there's a very interesting experiment in Alberta back in the 1990s. A friend of mine did his dissertation around this, where they start giving a little premium to primary care physician if they were ready to get informed and pay attention to the determinants of health of their patients. So more data, which is the ideology here. And in fact, it produced a lot of dissatisfaction among the healthcare providers themselves because they feel completely powerless. What it is to know that Mrs. Smith has this health problem mostly because of a housing situation, if you have no way of solving the housing situation. What it is to know about, her history of being in a violent environment, if you have no way of intervening there. And I think this is the limits of the data, the so-called magic of data, that knowing more will help us do more things. And at this time, I think the idea is that, so this is the question we ask, who does the work of care in a data-rich environment? Is it a role for the primary care doc, for instance, to do that? There are places where they say, no, maybe, but it could be the role of the institution to which the doctor is attached to do that kind of work. And we have seen experiment like that in UHN in Toronto, but mostly in the US, where we have seen large hospitals starting housing projects for their patients. It's one of the impact of the ACA is that if you have to pay for readmission, suddenly you try to find a way not to have to readmit patients. So either you ration, so you make sure they never enter your system in the first place, which most of them in the end did, or you try to find a way to make sure that they will actually benefit from some sort of social, the 90% that nobody cares about or do not care very much about. And so that's the first question. And the other question we have asked in the end, who does the work of care? Is it, if 95% of the problem is outside the healthcare system, why do we insist to be the one in charge? And that's the other question I think we should all ask. It was probably known by most people before we had that, but now we have the data telling us that very, very clearly. I'm pretty sure that it's a question of less than 5 years since we will start to have dashboard in which all this information will be available. What will you do? What will you do when you discover that the reason the treatment is not followed? It's not because the person is dumb. It's not because she hasn't shared the decision with you. It's because the housing issue is such that it is impossible to do it. And for me, that's the real challenge.
Yes, please, Priyanka.
Sorry, I know I'm not supposed
No,
to
it's
have
good.
comments as one of the organizers, but I can't resist but make a sort of reaction to this. So I've heard the story from Bikram Patel, who is a psychiatrist who works on global health. And he has a story about like when he was starting working and earlier in his career, one of his colleagues and him were chatting about a patient they had who was very depressed. And she was seeing his colleague and she was depressed because she was a victim of domestic violence. So the reason that she had so many mental health issues was she was a victim of domestic violence. So between him and his friend, they had this discussion. So as a psychiatrist, what can I do for this woman? I mean, obviously she just needs to leave her abusive husband and then her mental health problems will go away, right? So this is sort of the classic thing about what is the role of the healthcare provider. And then Bikram, I think his perspective is the role of the psychiatrist, and I imagine if I can reasons why she's staying in that abusive relationship is to figure out how she can cope with her situation better. So for me, I mean, I imagine that obviously the influence that the health sector can have and the determinants that are outside the health sector, obviously the shift is often outside the health sector, but that doesn't mean that the role the health sector has cannot enable people to cope better with their circumstances and also decrease some of the inequalities that exist outside. In fact, that is one of the objectives of a health system and health providers.
But I don't control welfare payments. I don't control housing. I don't control the cost of food,
I think that's an excellent point, but yet beyond helping people cope, I mean, we can pour resources into helping people cope. I'm also a clinician here in Côte-des-Neiges, and I've had patients who come with multiple somatic complaints over the years, full body pain. And then they come and they look way better. And I'm like, well, what happened? It's like, oh, well, my husband got a job in the hospital laundry and now he's making $18 an hour. This is such a great job. And now we can move to an apartment. And like, I can't, if there were a universal basic income, I might not be dealing with this, but I can't control that. And yeah, I guess I could go start writing letters to the Prime Minister, but I don't think I'm going to be very effective.
But can I tell my anecdote? So, you know, Hopkins again, post-ACA, Hopkins, and then
No, it's good.
the surgeons, you know, the Junkers of the hospital system. They have never had to care about anything else that, you know, there is nothing that a deep cut cannot solve, like economists say. So those people suddenly, they discovered that readmission of patients will cost them money, their own money, because they were now responsible for that. And suddenly I saw with my own eyes, those people discovered that there were community organizations that they will have never heard about before that will bring food to their patient, that will see that, you know, they were compliant with their medication and so on. And suddenly I have seen the surgeons at Hopkins being ready to pay for that. You know, how could we contribute? Because it was very, and in a way, this is, for me, there was a very important lesson here is that it's maybe not for us to do it. But it means that we need to be connected with the 90%, the people that are doing the 90% of the rest of the job. The housing problem, but there are people in the community that could help for that. If you are cut from them because you say no, the problem is essentially a healthcare problem, a health problem. I'm the super person. I'm the super physician. I could solve everybody. No, it won't work.
So coming back to data, because I think actually, you know, this is really, I'm just reminding you of the title of the slide. Because I think actually the conversation that we're having is the conversation we would have if we were actually working on linking health and social data. But we're not really in Canada, essentially at all. We're talking about, we're still stuck in the conversation about linking hospital data to primary care data or maybe home care data, but very little to social data, you know, really at all. And so, you know, and I have a big soapbox that I stand on about how, you know, all of this work is happening out there in primary care in the community. And for every 3,000 people admitted to the hospital, there are 160,000 visits happening in primary care every day. And those things are invisible to us because we're not harvesting the data from the primary care sector at all, which means that we have no idea what's happening where people live. But actually, maybe none of that matters at all. And maybe we should stop thinking about how do we integrate the data points in people's journeys in the health system and start thinking more about these social data conversations. And maybe actually, you know, I can survive not knowing whether my patient was or wasn't admitted to the hospital or what for, like my famous story about the person who showed up and said, I just got discharged from the hospital because I had a bladder infection. And I thought, that doesn't really make any sense. Why would you get admitted to the hospital for a week with a, well, it turned out it was her gallbladder, but it took me like a week to figure it out because, you know, she remembered the word bladder, but, you know, and so that on the one hand, that's absurd, but on the other hand, you know, this is what happens when systems are disconnected, and perhaps it's that classic thing of we're shining a light on the health sector data and therefore missing that 90%. And so what is gained and what is lost in that conversation. I haven't heard anyone speak yet about the corporate uses of such data and who is figuring it out at speed and linking everything everything to be known about me, my postal code and what kind of brown leather boots I looked at once and where I like to go on vacation and how much I use the healthcare system and, you know, packaging that up in a way to sell something to me. And I just wonder where we think all of that fits in.
So I think PGU stated that at this meeting of data miners in Chicago, the focus was on multi-level information systems. And I see that as a real opportunity here because if we had more data on social drivers of health, which comes from multi-level systems and connecting that to outcomes, then we may turn the needle to say that actually we have to, given the disproportionate impact of social determinants, that in fact we need to pay more attention to what the data is pointing in terms of the relative importance of health outcomes. And that may have very important implications for the direction of the workforce, which is we don't need more people in hospitals necessarily. Or if we had more people that were making sure everybody had adequate shelter and access to good nutrition and opportunities for physical exercise, that might decrease the demand for facility-based care because you've got more effective primary and secondary prevention associated with a more salutogenic environment. So to me, the issue is that maybe what we need is actually more data, but in a different place, and then look at how the system can bring workforce opportunities so that that's part of the prescription for better health for the society, rather than us thinking that it can only be done in a clinical domain.
Yes, please.
All right. So this is for the sake of having an interesting debate. I do agree as a data geek and scientist that more data can always help, it's never a bad idea. However, I'm going to take a page out of his book and ask the question, is it really more data that we need, or more willingness on the part of decision makers and policymakers to actually do something about the social determinants of health and start putting money where we know we already have a lot of data, and we already know that the housing and other issues related to social issues, poverty, etc., that are very complex, wicked problems, as we say, are really behind, or the layers and layers of issues that underlie a lot of the health outcomes. So what we really do need is really willingness on the part of policymakers and decision makers to start, and the broader society to really start doing something about that.
Is the mic on?
Is the mic on?
Oh, yeah.
That's a good question. It doesn't appear to be, but it's great. And so I'll just say that, I think this is a critical point, and those of us with scientific training and backgrounds like to imagine that somehow there's a relationship between evidence and policy, but it's a circuitous route, and this also, this has been studied in the social sciences by people smarter than myself. And just to say that I think, when we think about what causes people to make decisions about where they're going to put public dollars, for example, we wouldn't just want to live in a world where evidence rules, because all of those other factors like trade-offs and, political acceptability and, fiscal constraints, et cetera, are the work of democracy. And so it speaks to this question of should Marianne be writing letters to the Prime Minister? And I would say, yes, she absolutely should be, not because she doesn't have enough to do, but because we want to influence through more than just evidence. We also want to influence the public conversation that changes people's minds, which is not solely, we would never want it to be solely an evidence-based conversation. We want values and democratic, decision-making to play a role as well. So it's complicated. But not as complicated as the question of integration, which of course is the dominant conversation happening right now in Canada in so many policy circles. How do we integrate between primary care, specialty care, community care, hospital care? And it comes back to the conversation that PG was helping us to lead earlier. What is lost when we focus so much on integrating within the healthcare sector, at times to the detriment of the places where health is really created, which is in communities and around the social determinants. And this differentiation at the World Health Organization and other, kind of multilateral institutions around moving from primary care to truly primary healthcare, which is about also community engagement, becomes a more important thing. But it's pretty heretical in the current conversation to say, well, integration, really, who cares? When it's really the conversation that everybody is having. So what would you like to say about that, PG?
Just briefly mention, so Alberta was a very interesting case in point because you have in Alberta, on the one hand, they're among the first provinces that did what the transformation, I'm not allowed to call that a reform, it's a transformation. So the transformation that has been introduced by the Quebec government, they had that for a few years now, and we could see the benefit of an agency to manage hospital and basically secondary and tertiary care. It works very well, actually. It's a strong, good model and unity of command, incredible capacity. Evident, there is a benefit of having this system. We knew minutes after minutes if ICU beds were used by COVID patients. We never passed the red line because we were able to monitor that in real time. We're able to move workforce from one institution to another without having to be embarrassed by union contracts and whatever, which is a big advantage. The big thing in Alberta is the primary care system is in a completely other planet, and the two systems have never really talked to each other. And in fact, it's not bad that way. Of course, there is an information system, data connecting the two. So your primary care doc, you are able to access the data on but the patient, by the way, as well, is able to access every data. That's fine. But the two systems have evolved completely differently. And I came to think maybe this is a good thing. Maybe this is a way of not losing time continuously of thinking about the interface between the two and having the strongest possible primary care system that will be able to start working in the sense we mentioned of working on the 90% of the needs of the patient that are not covered by the health system and let the hospital system live by itself and its own life. So yeah, this is where I am now. It won't happen here.
Yeah, so just to emphasize, I think the integration is not necessarily with the hospital system, but with those other critical sectors. And that's primary healthcare, is that intersectoral collaboration and the community engagement piece, which interestingly enough is applied in many other countries in the world, or at least aspired towards, but here it sort of, it speaks to sort of a deaf audience. So I think this is a really, really important area that we need to transform, and that is how do we bring those systems, how do we really integrate social sector and health and primary healthcare sector? And this is one of the things that this thing called social prescription attempts to do. And I think what is fascinating about social prescription is that you really are relying on a workforce, a care workforce, the link worker, the connector, who does a lot of that business of matching sort of social needs, non-medical needs of patients to the kinds of resources that will enable them to meet those needs. And so we're talking about yes, we've lost that. So that critical sort of workforce that we don't tend to talk about. We mentioned this before in an earlier conversation, the non-regulated care workforce that there's no better care workforce. I think we need to do a lot more thinking about creative thinking.
So I'm sensing a theme. Did you want to speak?
So just is it?
Making sure it's red.
Oh.
Shout.
Oh. So just a question, how much research or data do we already have about how integration works and what doesn't?
So I'll pass to PG, but I'll just say that, the literature really differentiates between this concept of horizontal versus vertical integration. Like, are we talking about integrating within a community, or are we talking about integrating across silos from hospital to primary care to community? And I would say that the Canadian, so there is lots of research, I think, to suggest that for an individual patient, integration, vertical integration, as that person moves from one part of the system, we know that transitions of care are where damage occurs, right? So that's where we make errors, like medical errors. It's where prescriptions get lost. It's where people get given the wrong instruction. It's where they get readmitted because they can't access information. So at the level of the individual person, vertical integration for people with complex illness who are going back and forth between things is really important. But I don't think we have that many examples of really great, unless my global colleagues want to correct me, really amazing horizontal integration to point to and say, this is what it looks like, and this is what we know the health benefits to be. What would you like to add to that, PG?
Yeah, the thing I think is very clear is, in fact, you will be surprised how little we know about primary care in Canada. It's amazing about the real practice of people working in primary care. Try to find, do this one night, I would like to know how primary care is organized in the 10 provinces. So Quebec, easy. At least it's easy to open the page where you will have multiple answers to that same question, but it's very, very difficult to know what is. So your question about evidence is important, but we don't even know how the system, when I arrived in Calgary, the first thing I said, do we have at least one paper describing the primary care system that has been slowly built from bottom up by the physicians over? No, there was not a single description of the system available. And that's a problem, because if you don't have that, it's very difficult after that to understand in which context the transition is taking place. And that's a major issue. And then I could tell you the story of the relationship between this place and the Jewish at the beginning. That's very interesting too.
In his own right, Diego Rivera, who did much art that focused on working people. And as we think about this seminar and what is with the people we have, WHO is anticipating a 10 million health worker shortage globally by 2030. And that is based on projections from the pre-COVID days. And so I suspect it will be actually much larger than that. So if we think about relationships, if we think about data and what are the places where we want to be investing our time and energy around data, and how could data be used to build a better and more responsive workforce in primary care? And if we rethink this question of integration, because we're hearing a theme in this room today, I think, around less worrying about the hospital, more worrying about the community service. What does that look like from a workforce perspective? We'd like to put forward that these are the questions that should drive the next phase of inquiry around health human resources for primary care, and that we probably need to push ourselves a little bit around what we believe the answers to be, because the thinking that we have used thus far on these three themes is what has gotten us to where we find ourselves today, which is a rather uncomfortable position.
I have nothing to add.
Perfect. So I think part of the answer has to be to engage the powerful people in the healthcare system who are generally the physicians. I have heard over my long career, way too many physicians be disparaging of primary care and community resources. And a cardiologist, when I was a young medical student, saying, I don't deal with that. I'm a cardiologist, sort of not wanting to deal with the implications of a person's disease on their life. Or a neurosurgeon saying, I don't want the CLSC to be, determining when I discharge my patient from the hospital, like the availability of follow-up services. So this example that you brought, PG, of the American model, where surgeons are paying out of their own pockets when people are readmitted. I mean, this is a very interesting idea. Not that I, as a physician, kind of like that idea, but just like, how do we make people accountable for the person's whole care? Because I think we are really encouraging this siloed, like, I just take care of this piece and the rest, like, I don't deal with. And I think we have to engage these powerful actors within the healthcare system to actually look at the whole big picture. And that's the end of my point, but there is one comment in the chat that I wanted to raise. So from Deborah Danoff, do we need more data? Do we need to use the data that we have? Do we need to learn how to use the data in a true change process? And is asking for more data just a stalling measure?
Please. Great provocative questions. Yes.
I didn't have the answer to that question. I just want to add another layer, just to say that because a theme that went around the conversation was the importance of establishing good health information systems. And so I was wondering, to which part of, improving the healthcare system that comes in. And I also think we really need to think about the global aspect of it, because as developed countries try to address this problem, the developing countries sort of suffer, as I mentioned earlier. So how do we integrate that also?
I mean, they're great questions. So on the question of health information systems, I will say, if you could go back in time to the origins of primary care at the beginnings of Medicare in this country, we made a choice early on around family physicians who were and still remain the dominant workforce for the provision of primary care services to be independent practitioners, right? So billing the government, but essentially functioning as small businesses and contractors. And the knock-on effect of that remains to this day, and including our decisions around information technology. PG and I reviewed a national organization that shall remain unnamed that funded a lot of the electronification of primary care in Canada. Our IT decisions, because every computer on every family doctor's desk has a different chart, and of course the owners of those, and I'm not afraid to say is because we know it to be the case that we have now TELUS Health in Canada owning 75% of the market of all of those electronic medical records in primary care. And the data blocking that goes on by TELUS and its equivalents across that sector is very significant. And so we find ourselves in a situation in primary care where our patients can't access their own data. We can't access it as clinicians in a way that feeds back to us and allows us to improve care. Researchers can't access it without paying for it on the schedule that the EMR companies want to give it to us at, and it won't intersect with the data flow from hospitals, let alone in the social determinants of health. So I would guess I will say it's a long-winded and somewhat ranty answer to your question. The health information technology conversation is a data conversation. They are one and the same. There is no daylight between them, because none of these companies believe that they are in the business of building electronic charts. They believe that they are in the data business, and that is where the money is, both literally and also figuratively, in terms of answering important questions for research, or supporting quality improvement, or helping to improve the clinical care for an individual. Did you want to say something about that?
Or just to add to that, I guess I'm having trouble understanding why it's so difficult logistically for the organizations that advocate for physicians, CMA, the Medical Association, the one that advocates for family medicine, the FMS, all the different ones, why they can't figure out how to get together and advocate in such a way that it makes it work for physicians and patients.
Tim, thoughts about that?
No, I just want an opportunity to respond to the previous provocation.
Oh.
So I'm joking. But I think you're raising a really important issue, and it relates to your final slide on what are the workforce implications. And with all due respect to the massive intelligence and genius of clinicians, they're not trained to design and run systems. And the reality is we have a massively complex system related to trying to improve the health of the population. And the discussion on data is just an example of that. Thinking about it, what I need today to manage the care of my patient doesn't generate a design of the information system that is actually best for the population's health.
Yep.
And so I think a primary workforce, and I'd say a disproportionate workforce constraint we have, is we don't have any good training of health systems designers and developers who are versed in the complexity of the different functions that define every health system.
We have them, they're just not working for us.
That's, well, I think you may be right on that front. So we need to crowd them in. But that may be one of the ways in which we can start to get the shift in the behavior of the system, rather than thinking just more of existing workers is going to make a difference.
Well, as an example, in the US right now, they're increasingly training physicians in medical informatics. And there's actually, you can actually get certified in clinical informatics. We don't have that here, at least not to the same extent. And if we had something like that, or it started that process, it might be some way of helping, because it's actually, if you think about it, physicians, scientists, others who actually understand the system, IT, who need to be able to create that integration. It has to be, like you said, a multi-system process, or people, a team, a real team effort, and people who actually understand the healthcare system.
At our school, we call it the David Buckridge program.
Yeah, that's good.
So I think we're getting home, but just to say, we hope that this has been thought-provoking. That was our intention, is to challenge these assumptions, and thank you very much for the warm welcome.
You're absolutely not getting the hook. No, well, we would like to continue this like much longer, but unfortunately people have other things to do. So it's not a hook really. It's more like a denouement. How's that? So thank you everyone for your presence, for your stimulating questions. Thank you very much to our two speakers, to Dr. Martin and Dr. Forêt, for your very thought-provoking comments. I think this has been incredibly worthwhile for all of us, and I'm sure Danielle and I will fix this by tomorrow.
No problem.